So today we're going to chat about antimicrobial stewardship in the era of COVID-19, and I'm hoping to present data to you regarding national trends regarding antimicrobial usage in Canada, as well as antimicrobial prescribing patterns in the pandemic, as well as evidence of rates of secondary bacterial infection. Some interesting studies that have recently been published looking at rates of secondary bacterial infection and prevalence of secondary bacterial infection and concomitant bacterial infections in patients admitted with SARS-CoV-2 infection. So I don't have any disclosures, and we're going to talk about antimicrobial stewardship efforts in the era of COVID-19. We'll talk a little bit about the Choosing Wisely campaign and some management strategies for patients presenting with respiratory tract infections during the pandemic. And then we're also going to look at antimicrobial use amongst hospitalized patients with COVID-19. So in light of this pandemic that we're all navigating and trying to find the best ways to optimize provision of healthcare, it's important to keep in mind that there are other public health crises that are occurring simultaneously. With respect to other public health crises, we can see increasing rates of sexually transmitted infections such as syphilis in the province, as well as increasing rates of HIV. But today we're going to be talking about the public health crisis that is antimicrobial resistance. I'm sure most of you are familiar with the fact that we're seeing multi-drug resistant strains of Neisseria gonorrhea, ESBL-producing organisms, increasing rates of C. difficile infection, the potential for carbapenem-resistant Enterobacteriaceae in different parts of Canada, multi-drug resistant tuberculosis, multi-drug resistant Pseudomonas aeruginosa infections, and fluconazole-resistant Candida infections, and of course, methicillin-resistant Staphylococcus aureus. Lots of multi-drug resistant threats to our patient population, and all of these together represent a crisis in terms of antimicrobial resistance. In 2011, Dr. Margaret Chan, who is the Director General of the WHO, said, "In the absence of urgent corrective and protective actions, the world is heading towards a post-antibiotic era in which many common infections will no longer have a cure and once again kill unabated." But this concept of antimicrobial resistance is not a new one. More than 75 years ago, Sir Alexander Fleming, who discovered penicillin, said in one of his interviews following receipt of his Nobel Prize, "The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism." So this concept of antimicrobial resistance is certainly not a new one. Many of you might be familiar with the Review on Antimicrobial Resistance, this report that was published in 2014, and predicted that antimicrobial resistance would kill more than 10 million people by the year 2050, surpassing that of cancer and diabetes combined. The Council of Canadian Academies also published a similar report in 2019 with interesting projections for Canada, predicting that for 2050, there would be a 40% rate of antibiotic resistance to first-line antibiotics, a deaths of 13,700 people, and increasing costs to the healthcare system surpassing $7 billion. So let's take a step back and look at what trends are looking like before the pandemic. The Canadian Antimicrobial Resistance Surveillance System report gathers data on multi-drug resistant pathogens and different hospital and community-acquired infections. So here we can see rates of MRSA bloodstream infections, and you can see between 2014 and 2018, the overall rate of MRSA bloodstream infection has been increasing in Canada, and even healthcare-associated and community-acquired MRSA bloodstream infections, both of those specifically have been increasing as well. So the rate of potentially fatal bloodstream infections caused by antibiotic-resistant organisms has been increasing, and specifically for community-acquired MRSA bloodstream infections, we've seen an increase by 140%, of which nearly half of those cases are associated with injection drug use, which certainly highlights another potential crisis in our healthcare system, and that of the opioid crisis potentially as well. We can also see that the rate of healthcare-associated vancomycin-resistant enterococcus bloodstream infections have also been increasing and have more than doubled between 2014 and 2018. If you look at rates of carbapenemase-producing Enterobacteriaceae that could confer resistance to carbapenems, we can see increasing rates of colonization amongst our patients in Canada, but we can also see increasing rates of carbapenemase-resistant infections. So the increase in the number of patients testing positive for carbapenemase-resistant organisms and being colonized with carbapenem-resistant Enterobacteriaceae has increased by more than ninefold between 2014 and 2018. Interestingly, between 2015 and 2018, we saw some mild decreases in rates of C. difficile infection, specifically hospital-acquired C. difficile infection. And it will be interesting to see the impact of COVID-19 on not only antibiotic prescribing patterns, but risk of C. difficile infection. And it's certainly possible that rates of C. difficile infection may be increasing. We know that antimicrobial use in humans continues to increase. Antimicrobial prescription rates for Canadians aged 65 years and older continue to increase, particularly in women. So in this graph on the left side, you can see rates of antimicrobial prescriptions per 1,000 inhabitants between 2014 and 2018, stratified by age. And on the right side, you can see the similar trends for men. We can also see that antimicrobial purchasing by hospitals increased by nearly 30% between 2014 and 2018. And we can also see an increase in the use of different reserve antimicrobials, so antimicrobials that are reserved for treatment of multi-drug resistant infections. That rate has increased by nearly 10%. And one in particular to highlight is that the use of carbapenems has increased by more than 120% in the community setting, where we've seen a near doubling in the use of ertapenem on a national scale between 2014 and 2018. So in light of the COVID-19 pandemic, which is posing a threat to antimicrobial resistance, I think it's important to highlight the rates of concomitant bacterial infection and secondary bacterial infection that we can see amongst patients admitted with COVID-19. And so I'm going to highlight some data regarding antimicrobial prescribing patterns and trends that's been published through the Public Health Agency of Canada. So to start off with here, this is data that only goes until August 2020. So take this with a grain of salt, but there has been a decrease in community dispensing of antimicrobials amongst all age groups, about 30% for April and May of 2019. However, that could be related to less patients seeking care and healthcare avoidance during those initial months of the pandemic. And it's certainly possible that those rates could be increasing with increasing access to healthcare and increasing prescribing patterns as well. But all provinces had decreased overall or had remained stable in terms of community drug dispensing between 2015 and 2019. And so I think it'll be interesting to see as we gather more data on a national scale the impact of the pandemic on prescribing patterns, looking at more recent months in 2021. So this graph highlights the prescribing patterns in family medicine offices in the blue line, and then non-family medicine prescribing patterns in the red line. And again, during those initial few months at the beginning of the pandemic, we did see some decreasing prescribing patterns, but it will be interesting to see the overall trends and as we collect more data regarding national prescribing patterns. This data highlights the weekly incidence of patients hospitalized with COVID-19, again, between April and October of 2020. And again, this data is obviously a little bit older, but the majority of patients who were hospitalized with COVID-19 during those early stages of the pandemic had high rates of underlying medical conditions, including diabetes, lung disease, and heart disease as well. During this time period, about 25% of hospitalized patients were admitted to critical care, and the approximate mortality rate that we were seeing at that time was about 16%. So let's talk about the trends of antimicrobial use amongst patients who were hospitalized. So this data is derived from the Canadian Nosocomial Infection Surveillance Program, which is a collaborative effort between PHAC and AMI Canada and different Sentinel hospitals across Canada. So this consists of 78 acute care hospitals in 10 provinces and 1 territory that conduct national surveillance of hospital-acquired infections. So overall, 64% of patients who were hospitalized with COVID-19 received an antimicrobial. And we do know that receipt of an antimicrobial was more common amongst patients who were admitted to critical care at a rate of about 86% versus patients not admitted to critical care at a rate of about 58%. We can see similar trends in terms of antimicrobial prescribing if we look at influenza data. So if we compare this to data from 2006 to 2010 with respect to influenza surveillance programs through CNISP, we can see that 74% of patients hospitalized with laboratory-confirmed influenza received an antimicrobial. With respect to the most commonly received antimicrobials that we're seeing in Canada in terms of national trends, the most commonly prescribed antimicrobials for patients with COVID-19 included azithromycin, ceftriaxone, and then beta-lactamase inhibitors like piperacillin tazobactam. So PHAC data suggests that the proportion of patients who were admitted or hospitalized with COVID-19 and co-infected with a bloodstream infection was about 7%. And amongst patients with COVID-19 who were admitted to critical care units, about 19% were co-infected with a bloodstream infection. Interestingly, this ended up being isolation of more bacteria like coagulase-negative staphylococci, which could be indicative of central line-associated bloodstream infections and other hospital-acquired infections acquired while admitted to critical care. With respect to this graph here, you can see trends in antimicrobial usage. Again, this is a bit older data from March to October 2020, but you can see that the most commonly prescribed antimicrobials were agents including ceftriaxone and azithromycin, as well as other agents including meropenem, piperacillin tazobactam, and vancomycin as well. Interestingly, for patients admitted into hospital and who were found to have a bloodstream infection, the median number of days from admission to positive blood culture was about 9 days. So keeping in mind that patients who are admitted to the hospital, especially critical care units, are at risk of different hospital-acquired infections, including central line-associated bloodstream infections and ventilator-associated pneumonia as well. Interestingly, we also saw some increasing rates of antiviral use amongst patients hospitalized with COVID-19, especially during the early stages of the pandemic. Most commonly prescribed antiviral agents that were prescribed in patients confirmed to have SARS-CoV-2 infection included agents like oseltamivir, about 6.4% of the time, although there is no efficacy of oseltamivir for COVID-19. And then also a variety of different other antiviral agents, which could be reflective of some antivirals that were being studied and were initially thought to possibly have a therapeutic effect for patients with COVID-19. So overall, from this Canadian data, we can see that antimicrobial use amongst patients hospitalized with COVID-19 had declined during those first few months, but it's certainly possible that a recent increase is being seen, and I think more data needs to be collected. We can also see a higher prevalence of antimicrobial use amongst patients admitted to critical care units compared to other units. And that initial increase in antiviral use during those first few months is also noteworthy. But the proportion of patients hospitalized with COVID-19 and found to have a bloodstream infection is relatively low. So there's a few systematic reviews I'd like to share with you that have looked at co-infections in people with COVID-19. So one of the first studies that I'd like to present to you, this was published in 2020, and this was a systematic review, and they aimed to look at the burden of co-infections in patients with COVID-19. So they searched databases for studies of any design which reported data on co-infections in patients with simultaneous SARS-CoV-2 infection from January to April 17th, 2020. And overall, they included 30 studies and included approximately 3,800 patients in the study. And this included patients in China, the United States, Spain, Thailand, and Singapore. So for hospitalized patients with COVID-19, the overall pooled proportion of patients who had laboratory-confirmed bacterial co-infections was 7%. And the rates of laboratory-confirmed bacterial co-infections amongst patients admitted to critical care units was slightly higher at 14% for patients admitted to critical care. With respect to co-infection with viruses, an estimated 3% of patients hospitalized with COVID-19 had a confirmed viral co-infection. So in terms of the different bacteria that were isolated amongst patients found to have a concomitant bacterial co-infection, these included bacteria like atypical pathogens such as Mycoplasma, and then other Enterobacteriaceae like Klebsiella and Enterobacter, and other non-lactose fermenting gram-negatives, including Pseudomonas aeruginosa as well, and other multi-drug resistant pathogens, but certainly at a lower proportion compared to Mycoplasma. Of those patients, the 3% of patients that had a concomitant viral co-infection, these included viruses like RSV and influenza A, as well as rhino and enteroviruses as well. So from this data, we can see that overall 7% of hospitalized COVID-19 patients had a bacterial co-infection, and that proportion increased to approximately 14% of patients with COVID-19 looking at studies including patients admitted to critical care. So this data does suggest that the rate of bacterial co-infections amongst patients with COVID-19 is relatively low, and it's certainly lower than that compared to influenza. So for patients who are admitted with a respiratory illness and found to test positive for COVID-19, unless there is clear evidence of a secondary bacterial infection or concomitant bacterial infection, looking at their blood and sputum cultures and clinical presentation, discontinuation of empiric antibiotics should certainly be considered for the vast majority of these patients. So some more recent data that's been published by our colleagues in Ontario. This is a systematic review that was published in 2020, and this was a systematic search of Medline, Ovid, EPUB, and MBase databases for English language literature from 2019 to April 2020. And studies were included in the systematic review if they evaluated patients with confirmed COVID-19 infection and reported the prevalence of acute bacterial infection. The main outcome in this systematic review was the proportion of COVID-19 patients with an acute bacterial infection and excluding any bacteria detected from non-respiratory tract or non-bloodstream sources. So they're only looking at positive cultures from a blood culture or a respiratory tract culture, a sputum culture. They found about 1,300 studies, but only 24 were eligible based upon their criteria, and that encompassed around 3,338 patients evaluated for acute bacterial infection in the setting of SARS-CoV-2 infection. So in this meta-analysis, bacterial co-infection was identified in 3.5% of patients, and secondary bacterial infection was identified in approximately 14.3% of patients. So we can see that the overall rate of co-infection with a bacterial pathogen upon presentation for patients admitted with SARS-CoV-2 infection was quite low at only about 3.5% at the time of presentation. And the rate of secondary bacterial infections amongst patients admitted with COVID-19 was around 14%. So the overall proportion of COVID-19 patients found to have a bacterial infection was 6.9%. And bacterial infection was certainly more common in patients admitted to critical care. That included a rate around 8.1% overall. But the majority of patients with SARS-CoV-2 infection received antibiotics, and that was at a rate of 71.8%. So the authors from this study concluded that amongst patients with COVID-19, the overall proportion of bacterial co-infection was quite low, but usage of antibiotics remained quite high. And there's certainly insufficient evidence to support widespread use of empiric antibiotics in patients hospitalized for COVID-19, particularly those without evidence of critical illness. So again, this just highlights some of their data from this meta-analysis that only 3.5% of patients were found to have a bacterial co-infection on presentation, and amongst nearly 3,000 patients admitted with COVID-19, about 14% of those patients developed a secondary bacterial infection after presentation. But we can see quite high rates of antibiotic prescribing amongst patients admitted with COVID. So they also performed a follow-up systematic review, and these authors, again, a similar group from out east in Toronto, aimed to also estimate the prevalence and associated factors of antibiotic prescribing in patients with COVID-19. So they did another systematic review, again, looking through a variety of different databases on literature published up to June 2020. And they included different randomized controlled trials, cohort studies, and case series with at least 10 patients. And the study participants that they included were patients with laboratory-confirmed SARS-CoV-2 infection. And the main outcome of interest in this systematic review was looking at the proportion of patients who were prescribed an antibiotic, and then going one step further and stratifying that by geographical region, the severity of their illness, and their age. So from this systematic review, they found antibiotic data was available for about 30,623 patients, And the overall prevalence of antibiotic prescribing was around 75%. And they saw increasing rates of antibiotic prescribing correlated with increasing patient age and higher rates of antimicrobial prescribing amongst patients who required mechanical ventilation, which certainly makes sense for patients who are admitted to critical care. The estimated bacterial co-infection, again, in the systematic review overall was quite low at about 8.6%, but keep in mind that nearly 75% of patients were prescribed antimicrobials. So as we can see here, antibiotic prescribing is significantly higher than the prevalence of bacterial co-infection, and that certainly suggests that a large number of antibiotic prescriptions are unnecessary, increasing the risk of preventable harm, including adverse events, C. difficile infection, and resistance. The type of antimicrobial seem to vary based on geographical stratification, as you can see in this figure. So in China, for example, we can see higher rates of fluoroquinolone prescriptions, whereas in North America, higher rates of macrolides, beta-lactam, beta-lactamase inhibitors, and cephalosporins, beta-lactams, and vancomycin as well. We can certainly see that such high rates of antimicrobial prescribing patterns are mirrored when it comes to looking at data for other viral infections such as influenza. And so the authors concluded that from this study, nearly 3/4 of patients with COVID-19 received antibiotics, and prescribing rates were significantly higher than the estimated prevalence of bacterial co-infection. We can see that unnecessary antibiotic use is likely to be quite high in patients with COVID-19, and it's clear that antimicrobial stewardship efforts are urgently needed to help mitigate the impact of COVID-19 on antimicrobial resistance. So in summary from this data, we can see that the impact of COVID-19 on global resistance is uncertain, but likely to be unevenly distributed amongst disease epicenters and populations. Pandemic-associated changes in human behavior and healthcare practices like decreased travel, physical distancing, avoiding hospital and clinical admission, improved infection prevention and control, hand hygiene, and environmental cleaning may potentially mitigate against some of the impact of COVID-19 antibiotic use on overall antimicrobial resistance, but that is certainly unknown, and more data needs to be collected on the overall impact of this pandemic on antimicrobial resistance. There's certainly diagnostic uncertainty in identifying bacterial infection in patients with COVID-19, and we can see a wide variation in terms of current guidelines recommending different approaches for the use of empiric antibiotics. Some guidelines advocating for preserving use only for patients with severe COVID-19, and other guidelines using more of a tailored approach to withdraw antimicrobials based upon the results of blood and sputum cultures and clinical defervescence. Our findings definitely support the need for clear and consistent guidance on which patients with COVID-19 would derive the greatest benefit from empiric antimicrobial therapy, and also trying to stratify which patients the risks of antibacterials would outweigh the potential benefits. So there's definitely opportunities for more research in this field, and opportunities for improvement in terms of diagnostics to evaluate for bacterial co-infection, as well as antimicrobial stewardship interventions to aid in the to help with the antimicrobial prescribing patterns that we're seeing for patients with COVID-19. So the last thing I want to do is also just highlight the Choosing Wisely Cold Standard, which provides a toolkit for using antibiotics wisely in the era of COVID-19. I think it's important to acknowledge the fact that there are a lot of different factors that come into play with respect to antimicrobial prescribing patterns, including healthcare system characteristics and social characteristics, and different healthcare culture beliefs around antimicrobials, prescriber knowledge of infectious disease and antimicrobials, as well as different social norms that can impact antimicrobial prescribing patterns. So the Choosing Wisely Canada campaign has a variety of different resources that you might find useful to incorporate into your practice, looking at stratifying whether patients need to be seen in person or could be safely assessed through virtual care, and providing different indications for virtual versus in-person visits for a variety of different clinical syndromes that are commonly seen in outpatient clinical practice, including otitis media, pharyngitis, sinusitis, COPD exacerbations, and patients presenting with respiratory illness that may be suspicious for COVID-19 or confirmed for COVID-19, and other upper and lower respiratory tract infections as well. They also provide great guidance in terms of the use of antimicrobials for a variety of different syndromes, including patients with COVID-19 confirmed influenza or other influenza-like illness, emphasizing that for patients who are otherwise well in the community setting with a confirmed diagnosis of COVID-19, that there's no role for antibiotics unless, of course, there's evidence of clinical deterioration and evidence of a secondary bacterial infection, and we already know that those rates are quite low. In addition, they also provide guidance regarding the use of antibiotics for a variety of other syndromes and risk stratification scores that you can use to help decide whether your patient requires antibiotics or not. Also, shout out to Regina for the viral prescription pad. And this can be a very useful tool to provide for patients with presenting with a suspected viral infection, emphasizing the use of non-antibacterial agents, including acetaminophen, ibuprofen, and other agents, as well as including a contingency plan for when to seek medical attention again. In addition to viral prescription pads, there are also delayed prescription pads that can be employed for other syndromes, in which case you may simply provide a prescription, but delayed, and that should only be filled if there's evidence of clinical deterioration supporting a secondary bacterial infection. They also have a variety of different posters that could be put in different family medicine practices that might also mitigate against the risk of inappropriate prescribing. So there's a few studies that I want to share with you, but for the sake of time, and so there's also opportunity for questions, I'm only going to touch base on one of these studies, which is my favorite one. And this one is a really cool trial that looked at the concept of nudging. And so a nudge is something that influences decision-making through subtle cognitive mechanisms. And this has been shown to change human behavior in a wide range of applications outside of medicine. And this was a really interesting study that used this concept of a behavioral nudge and showed improved rates of prescribing patterns in outpatient clinics. So they used a nudge, which was a public commitment poster, and they placed these posters in exam rooms with the provider picture and their signature advising that they're committing to only using antibiotics appropriately. And in this randomized controlled trial, they actually found a 20% reduction in prescribing patterns just simply from having that poster visible in the waiting room. It's possible that this improvement in prescribing patterns may have been on the part of the prescriber and committing to only prescribing antimicrobials when appropriate, but also maybe could relate to the patients and maybe asking for antibiotics less by seeing that poster, or also creating a dialogue to discuss the appropriate use of antimicrobials and the importance of antimicrobial stewardship. So this is an example of one of those letters that was put in the family doctor's office, and that in of itself was a low-cost, high-impact intervention in terms of reducing antimicrobial prescribing patterns. So I wanted to thank you again for the opportunity to present some data. We're looking at prescribing patterns and antimicrobial resistance trends in Canada, and I'm happy to address any questions at this time.
Awesome, thanks, Shaquille. I see Megan has posted. Megan, do you want to unmute and ask your question? Or maybe there's questions in there anyways.
I can read it out, Jason, if that's okay.
Sure, go ahead if you want to take it bit by bit there.
Sure. So thank you for providing this information. I think that many of us here agree that antimicrobials are broadly overprescribed in COVID-19. I feel as though there has been quite a bit of education of prescribers around appropriate antimicrobial prescribing practices. I myself have taken to some of the prescribers, and they definitely understand the literature around this. I wonder if we can take a more targeted approach to prescribers with regards to antimicrobial stewardship in the context of COVID-19. I'm wondering if education is really the barrier here. Is it possible that there are larger other barriers, fear-based prescribing, for example, that are skewing prescribing practices, and how would we address such barriers? Yeah, I think that's a very legitimate concern, and I think that often when we look at inappropriate prescribing patterns for a variety of different syndromes, it's often not a lack of education or knowledge, but there's other factors that certainly influence prescribing patterns, and emotion may be part of that. I think there's definitely more evidence that needs to be gained and ascertained in terms of how to identify a patient who is unlikely to have a concomitant bacterial infection, whether there are stratification tools and risk score calculators that can be employed, and then having local guidance and guidelines for patients with COVID-19 to help provide information and reduce variation in practice can also be useful. But I think it's very challenging to overcome a lot of those social norms and emotion and fear that could be contributing to inappropriate prescribing or high rates of antimicrobial prescribing for patients with COVID-19. But I think there's definitely opportunity for innovation and improvement.
Yeah, for sure. Thanks. I see too that Angie put in the link there for that Antibiotics Wisely campaign. So for anyone who hasn't met Angie Palin, she's the Choosing Wisely coordinator for Saskatchewan. So thanks, Angie, for plopping that in the chat there too. Are there other questions for Dr. Peter Mohammed? Feel free to unmute yourself or put them in the chat.
Hi, Shaq. It's Kristen. Thanks so much for your presentation. I guess I will just kind of echo a bit of what Amanda has said here, that it's likely very multifactorial as to why we have this overuse of antimicrobials. And at this point, with limited resources for stewardship and a lack of guidelines, do you have any practical tips on things that we can be looking for, especially as pharmacists, to approach physicians and have these conversations? And then as well, a second question on the one study that you had shown as far as the usual pathogens in these patients. I've seen other reviews with other pathogens, strep pneumo, Haemophilus, Staph aureus, and that atypicals would be less likely of a concern. So just curious as to your opinion on what we should be covering empirically if antibiotics are indicated.
Mm-hmm. Yeah, no, that's a great question. I think if a patient, presents with suspected pneumonia and undifferentiated, I think it's really important to optimize diagnostics, so ensuring that patients who are admitted with pneumonia of unclear etiology as well as increasing oxygen requirements that appropriate testing is performed not just for SARS-CoV-2, but looking for other respiratory tract viruses, as well as performing sputum and blood cultures if there is evidence of pneumonia on their imaging. Starting off there is a really good starting point, and if a patient has confirmed SARS-CoV-2 infection and their sputum and blood cultures are negative, that may be an opportunity to withdraw their antimicrobials, especially if they're clinically stable and there's been no worsening in terms of their clinical status. Looking for other atypical pathogens, there may be variation in practice in different studies in terms of what they perform to look for concomitant bacterial infections. So you might see variations in how often a urine Legionella antigen is being sent if a patient has risk factors versus other molecular-based tests for atypical pathogens. So that might have led to some of the variation in the different types of secondary bacterial infections. But I think overall, from the systematic reviews that we kind of discussed today, we can see that the overall rates of concomitant bacterial infections are quite low. So I think if someone is clinically stable and has no evidence of a bacterial infection, that's a good time point to reassess their antimicrobial therapy to determine if it's, one, even needed, and two, can we switch to oral or potentially even reduce duration of therapy if there's no evidence of a true concomitant bacterial infection.
Right. Other questions? I like, Shaq, that you brought up that Daniela Meeker's study there, because that was something when we first started with trying to get into the communities in Regina, that was one of the first things we had put forward. And so actually Meadow Primary Healthcare Clinic in Regina had used, we made up one of these posters for them, and so that the doctors had something that they could post in there, and their commitment to being antimicrobial stewards. So we've never really followed up and haven't been able to interact with them as much as we'd hoped. So, but that would certainly, when you're looking at especially primary healthcare, that's a relatively easy intervention. That's something that would be, I'm certainly interested in trying to continue to connect with primary healthcare clinics and push that stuff a little bit harder. My question for you, somewhat unrelated, is I'm interested in your thoughts, and I attended a webinar maybe a week or two ago where they had talked about this a little bit. So I'm interested in your thoughts. When we're seeing, as you talked about at the beginning, reduced use of antibiotics, or reduced prescriptions, at least anyways, in the community in the last probably 8 months, over a year now, do you think that the increase in antibiotics, unnecessary antibiotics that we're seeing in acute care, do you think that's all going to level out? Or do you think the scales are tipped to one side in terms of the potential to push, further push antibiotic resistance?
Yeah, it's an interesting question. I think those initial few months where we saw decreased antimicrobial prescribing patterns likely relates to, to some degree, patients who were avoiding accessing care, and that might have led to some of that initial decrease. I think we saw similar trends with respect to new diagnoses of HIV and sexually transmitted infections like syphilis during those first few months, but that also related to less testing happening as a consequence of the initial stages of the pandemic and healthcare avoidance. I think it will be interesting to see what happens with prescribing patterns as numbers of patients with COVID-19 decrease, but the potential aftermath and the effects of high rates of prescribing on the ecological niche and prevalence of multi-drug resistant bacteria, it'll be interesting to see the aftermath of that. I'm also curious to know, and something to look at with PHAC data and CNIS data would be rates of C. difficile infection. I've certainly subjectively seen an increased number of referrals and patients admitted into hospital with C. difficile infection. I'm curious if you and folks in Regina have noticed a similar trend. But I think that would also be interesting to see is the rate of C. difficile infection, community and hospital acquired, and see if that's been impacted by the pandemic as well.
Sorry, anyone from Regina who can comment on, have you seen more C. diff patients at all? I think either way it would be there would be something interesting that we could look at too across the province and see, because it would be interesting even just to get that local data, even if we don't have something nationally, we can see if there's an association between our prescribing rates and C. diff increase in Saskatchewan too.
Mm-hmm. Yeah, it would probably be relatively easy to gather that data just looking at laboratory confirmed C. difficile infection.
Mm-hmm. All right, well, we are at 1 o'clock. So Dr. Pir Mohammed, thank you very much for taking the time and presenting to us today. It's an interesting topic, and I think there's a lot more data to be had from this, and we'll see how things come out in the wash. And I think for all you pharmacists who are tuning in and listening, you've seen the information, you've seen the data. So if you have any influence over prescribers in your local area, try and put that to some good and see if we can curb. But what I know in Regina are really high rates of prescribing for hospitalized COVID-19 patients, prescribing antibiotics. So thanks again, Shaq, and we will be back again next month, everybody. Thank you all for joining us today.